Assalamu alaikum. Hello friends. Welcome to Seek Light. Hope everyone is having an awesome day. If you are a pharmacist, subscribe to my channel. I promise it will be worth your time because I make a lot of informative videos. I have an important announcement to make. The videos which I present in my Seek Light YouTube channel will be available in a PDF format in my website www.seeklightdrug.xyz. The link will be given below the description box. Let's start the video. So 10 drug interactions that every pharmacist must know. A drug interaction is a reaction between two or more drugs, or it can be a reaction between a drug and a food, or drug or any supplement, or drug or medical condition. A drug interaction can make a drug less effective, increase the action of a drug, or cause unwanted side effects or adverse drug reactions. Although drug-drug interactions constitute only a small proportion of adverse drug reactions, they are important because they are often predictable and therefore we can manage it or we can even avoid it. So the frequency of these drug interactions are related to the age of the patient, the number of drugs he or she is prescribed with, genetic factors, environmental factors, diseases, and the absorption, distribution, metabolism, elimination differences, and the drug properties. The most important mechanisms for drug-drug interactions are usually inhibition or induction of drug metabolism. So they can be displacement interactions, competitive interactions, non-competitive inhibitions, allosteric changes in binding sites. Interactions involving loss of action of a drug are more frequent than those involving an increased effect. So it's likely that only 10% of potential interactions result in clinically significant event or a death. So serious clinical consequences are very rare, but we always recommend caution while prescribing a lot of drugs for elderly patients. Before moving on to the list of drug interactions, I would like to share this news. A dentist was suspended over a patient who bled to death after removal of 10 teeth within a week. The patient was on warfarin and the doctor failed to warn her the increased risk of bleeding. So it's very important to take a medication history of a patient. It's important because it helps in preventing prescription errors as well as consequent risks to the patient when taking any treatment or for treating any kind of conditions. So as a clinical pharmacist, you have to give a lot of importance to medication history because they are important to prevent such cases like these. Number 1, warfarin and vitamin K or phytonadione. So a patient who is taking warfarin, he should be advised not to take green leafy vegetables because they are rich in vitamin K content. So there is a moderate interaction with good documentation, that is number of reports with this interaction is really very good. Now what's the mechanism of this interaction or what is going to happen because of this? The thing is that warfarin is vitamin K antagonist. And again we are supplying vitamin K, so the effect of warfarin naturally reduces. Now how this interaction occurs is warfarin decreases the blood clotting by blocking enzyme vitamin K epoxidase reductase that reactivates vitamin K1. Without sufficient vitamin K1, clotting factors like 2, 7, 9, 10 have decreased clotting ability. So there will be change or fluctuations in the INR level, and vitamin K will completely antagonize the metabolism of warfarin. So warfarin effect is naturally reduced. So if these two are going together, if you're taking warfarin and vitamin K together, strict monitoring of INR is recommended. Number 2 is digoxin and quinidine combination. Now if digoxin and quinidine given together, it's going to cause a major drug interaction, and this drug interaction has an excellent documentation, and this drug interaction is very life-threatening. What happens is there will be increased level of digoxin in the plasma. Due to this, there will be a lot of adverse drug reaction to the patient. So digoxin is a narrow therapeutic index drug, so which requires TDM, that is therapeutic drug monitoring. So increased digoxin plasma concentration occur due to inhibition of P-glycoprotein by quinidine. So P-glycoprotein is a drug transporter which is important in the drug metabolism of digoxin. So what we can do is when giving digoxin and quinidine together is we can either reduce the dose 30 to 50% or modify the frequency. That is, when two drugs cannot be given together at a time, so we have to modify the frequency by at least 4 to 5 hours apart based on their half-lives. So, and always you have to monitor digoxin level if these two drugs are going to go together. Next we have on the list is potassium chloride and spironolactone. This is a major drug interaction and this has a fair documentation. So spironolactone is a potassium sparing diuretic. So a potassium sparing diuretic with a potassium chloride can cause hyperkalemia due to decreased renal clearance of potassium. Especially in a heart failure patient, we have to discontinue potassium supplement when spironolactone is initiated. And if at any cost, if these two drugs are to be given together, we have to monitor potassium levels in the patient. Next, number 4 we have on the list is clonidine and propranolol. Clonidine is a central alpha adrenergic agonist and propranolol is a beta blocker. So when these two are given together, it causes a major drug interaction due to pharmacodynamic synergism. So there is a risk of sinus bradycardia, elevated heart rate, and a sudden withdrawal of clonidine from adjunctive therapy with propranolol may cause fatal rebound hypertension. Now, why these many reactions occur? Clonidine is a central alpha-2 adrenergic agonist that suppresses the sympathetic nervous system. This activity leads to a decrease in norepinephrine amount. So when alpha-1 receptors become sensitized because of less norepinephrine, when clonidine is suddenly withdrawn, the result is large increase in norepinephrine and the sensitized alpha-1 receptors are stimulated, leading to an exaggerated vasoconstriction. The body cannot compensate for this response because the beta-2 receptors are already blocked when the patient is concurrently taking propranolol. So within 24 to 72 hours, a dramatic rebound hypertension is noticed. So when these two combination goes, we also have to check heart rate. We always have to monitor heart rate as well as we have to check for risk of sinus bradycardia. Number 5 on the list is selective serotonin reuptake inhibitors with tramadol. Now this combination will cause a major drug interaction and this has an excellent documentation. So what happens is there will be an increased tramadol exposure and decrease in its active metabolite M1. That is, the tramadol has an active metabolite called M1, so this will be decreased. So due to inhibition of cytochrome 2D6 mediated tramadol metabolism, this reaction occurs. So there will be risk of seizures and as well as serotonin syndrome and opioid withdrawal symptoms. The only thing which you can do is here is dose reduction and always monitor signs of respiratory depression or sedations. Next on the list is number 6, monoamino oxidase inhibitors and tyramine. So this is known as cheese effect. So when these two combinations are given together, it can result in acute attack of hypertension. So this is like an adverse drug reaction to monoamino oxidase inhibitors, usually type A. So this can occur when patients take food rich in tyramine like cheese, beer, wine, flour, beans along with the drug monoamino oxidase inhibitors like selegiline, racegiline, all these examples. So how this reaction occurs is there is a peripheral inhibition of MAO, that's MAO-A, resulting in less metabolism of tyramine. So normally it's metabolized by MAO. So this will enter. So when there is no MAO, the tyramine level will be high and this level will lead to release in norepinephrine which can cause increased blood pressure. So we have to monitor BP. Number 7, antihypertensive and NSAIDs. So it's a moderate drug interaction with excellent documentation. So when antihypertensives and NSAIDs are given together, there will be an additive effect on renal function as well as there will be decrease in renal prostaglandin production which can lead to elevated blood pressure. So NSAIDs will block both COX-1 and COX-2 enzyme which will impair prostaglandin synthesis. So this inhibition can result in increase in arterial smooth muscle tone as well as produce a dose-related effect on natriuresis and resulting in fluid retention. So by these mechanisms, NSAIDs reduce the effectiveness of commonly used antihypertensive agents like diuretics, AC inhibitors and ARBs. So because NSAIDs are always available as OTC drugs, so patients may be aggravating their hypertension by using these drugs. NSAIDs with the most profound effect on BP are indomethacin, piroxicam and naproxen, and NSAIDs that have an intermediate effect on blood pressure include ibuprofen, rofecoxib and celecoxib. Next we have on the list number 8, proton pump inhibitors with thyroid hormones, that is omeprazole with levothyroxine. So this is a moderate drug interaction with good documentation. So levothyroxine needs a normal gastric acid secretion for its absorption. So when there is decreased T4 effect due to decreased absorption, because we know proton pump inhibitors decrease the stomach acid, hence T4 absorption will be reduced. So we have to administer levothyroxine 4 hours before taking any proton pump inhibitor. The 9th one on the list is fluoroquinolones and corticosteroids. This is a major drug interaction with excellent documentation. So recently US FDA had put a black box warning on fluoroquinolones that there is enough data to suggest that it should be used cautiously in selected population of patients due to its risk of tendinopathy or tendinitis. So fluoroquinolones are prescribed for gastrointestinal respiratory infections. So there is increased risk of tendon rupture or tendinitis if it's given with corticosteroids, and this risk is seen more in age above 60 years, patients with transplants like renal transplant, lung transplant or heart transplant. And the symptoms of this drug interaction will be pain, swelling, inflammation in the extremities. Now what's the mechanism behind this is fluoroquinolones have a direct cytotoxic effect on enzymes found in mammalian musculoskeletal tissue, and it's also having chelating properties against several metal ions. So it can cause toxicity to type 1 collagen synthesis as well as promote collagen degradation. So these are these are based on some research which has been conducted to identify what could be the cause of this drug interaction or cause of tendon rupture or tendinitis. So always it should be used in caution, especially for elderly patients. The 10th one, statins with macrolides or azoles. So this is a major drug interaction with good documentation. When statins are given together with macrolides like erythromycin, clarithromycin, azithromycin or azoles like fluconazole, ketoconazole, there is a risk of myopathy or rhabdomyolysis. So this occurs due to inhibition of cytochrome 3A4 statin metabolism by macrolides or azoles, which result in increased exposure of statin. And the symptoms will be muscle pain in the calves area, thighs, joint pain, tenderness, weakness, particularly in initial months of therapy. So we have to monitor creatine phosphokinase to know if there is any muscle damage. Now rhabdomyolysis is a severe adverse effect of statin which may result in acute renal failure or disseminated intravascular coagulation or death. So prevention of statin-related myopathy involved is to avoid polytherapy with all these drugs which can increase statin exposure, and as well as use a low dose to achieve the therapeutic goal. And this mechanism of rhabdomyolysis is due to mitochondrial dysfunction, oxidative stress, several mechanisms derived from impaired mevalonate metabolism such as isoprenylation of small g proteins, genetic susceptibility. So all these are based on research theories that this could be the reason for risk of myopathy. So here I have a list of red alert drugs. These drugs are going to show drug interactions. They have excellent documentation. So you have to remember these drugs because for sure they are going to cause for sure they will cause some drug interactions. So these are warfarin, statin, macrolides, azoles, selective serotonin reuptake inhibitors, calcium channel blockers, amiodarone, rifampicin, isoniazid, digoxin, and anti-epileptic drugs. So these are some apps or websites which will help you to find drug interactions, because of course we are humans, we are not going to study or by heart the whole or entire lot of drug interactions with all these drugs. So to know them, we have useful apps like Lexicom, IBM Micromedex, Medscape, and we have websites like drugs.com, Drug Bank, RxList, RxISK, all this. So these apps and websites will provide you with drug interactions and the best one is Lexicom. Second best is Micromedics. I personally use Micromedics Drug Interaction Checker and Medscape because Lexicom is 1 month it's free. For the next month you will have to pay for the subscriptions. So hope this video was informative to everyone. If you have more drug interactions to add, you can add it in the description box so that everyone can know and learn from it. Thank you and have a nice day ahead.